All right, we're going to spend a minute now talking about back pain with related leg pain. So this is disc-referred leg pain. We believe it's from pathology of the disc, that it refers pain into the lower extremity, and that this pain, if it is truly back pain with related leg pain, it is a pain that is non-neurogenic. It has nothing to do with nerve root, okay? So if you take a look at these two pain patterns here, we're looking at pain that goes below the knee, but you can see that in this pain pattern here, right in the middle of the screen, you can see that the pain pattern is a little bit more diffuse. It doesn't seem to follow a narrow band. It doesn't seem to follow a particular dermatome. And so when you look at the top hypotheses, yes, it's lumbar disc disorder with lower extremity referred pain, or as in guidelines speak, it's acute low back pain with related lower extremity pain. You can see, of course, the other hypothesis is that it could potentially be sciatica, nerve-related leg pain. Okay, so if we go into the pattern, this type of leg pain, it's not that clear exactly who gets it, but we think potentially between the ages of 20 and 50 years of age that there's still enough material in the disc that that this type of referred pain can occur. I certainly have seen and believe that it can occur in various age groups. Okay, so it's not clear in terms of prevalence. When you watch the patient, just a quick thing that I want to note here is that you see a potential lateral shift. Now, not every patient is going to have this. You may see a flat low back and pain reproduction, typically with flexion or flexion rotation type movements, because those movements are known to be dangerous or damaging to the disc, right? Repeated flexion and rotation or rotation movements have been shown to be damaging to that disc tissue. All right, so you can see that there's leg pain. It's fairly diffuse in description. Let's move on from there. So if you go into the key findings for this condition based on the guidelines is essentially, does it centralize or peripheralize? And does it do it with repeated movements? So let me just lay it out very quick and clean. If you notice that there is a frontal plane deformity, a lateral shift, then it's important to do some type of repeated lateral shift correction. So shift them in the opposite direction and check if the pain changes in location, right? Ideally, we want the pain to be moving up towards the spine, centralizing. And if it gets worse, as long as it's moving close to the spine and out of the lower extremity, we're moving in the right direction. So we're going to use repeated movements of the spine because those repeated movements we believe might be shaping the discal material or the inflammation within the disc, and that's causing less pain referral into the lower extremity. This is not really about nerve root being, the disc bulging on the nerve root. Okay? And if that doesn't work, you can always use a manual lateral shift correction and repeat that, right? We need repeated movements. And if that begins to get better and no longer works anymore, then you move into sagittal plane, right? So if you've gotten rid of the frontal plane deformity, you can now start restoring extension. Remember, I mentioned the flat back. Okay, so I want to restore the lordosis, and I'm going to use repeated movements in standing. So this is a centralization assessment. If the patient is too irritable for that, if everything you try to do in standing peripheralizes or causes more leg pain, or for it to go further down the lower extremity, then it's valuable to move them into a gravity eliminated position. So here you note that we are now spine unloaded, right? We are supine or prone. Actually, we're prone here. And we're starting and meeting them where their tissues can handle it. So we can put them prone on pillows. We can slowly remove the pillows because we're trying to restore the lordosis. If they have a lateral shift, right, a frontal plane deformity, remember we've made a priority of fixing the frontal plane deformity first. So we might do a lateral shift correction. And this may be done over pillows as well. And as the frontal plane deformity cleans up, then we will move into sagittal plane and start doing repeated movements of prone on elbows. Can you do prone press-ups? You absolutely can. You just have to consider if the tissues in there are already somewhat irritable, does taking that tissue all the way to end range and doing repeated movements of end range extension, is that something that the patient can tolerate. So if it continues to centralize the problem, then hey, go for it. But remember that it does put the spine in a very extreme position. So we've made a decision to say prone on elbows and repeated prone on elbows is a reasonable position to be in, and eventually we're going to move them back up into function and start doing these repeated movements in weight bearing. Okay. One other thing I want you to consider, remember we've talked about these movement faults. What kind of movements create pathology in discal tissue? Excessive lumbar flexion, right? So we're going to have to change how they flex, what kind of strategy they use. Do they use their hip hinge and their knee hinges, or do they excessively bend at their lumbar spine? In the latest iteration of the app, we have added excessive rotation as well. So if you see patients who excessively rotate or excessively flex, we need to change that. We need to teach them to be more in neutral spine instead of excessively flexing or rotating. Okay, so that's how you would analyze, are they excessively flexing, and train them actually to keep their spine closer to neutral while moving in other areas. Finally, when you go into your treatment, actually let me point out one other thing. In the differential, technically, if it's truly referred leg pain from the disc tissue, there should be in the differential a negative lower quarter neurologic assessment and a negative straight leg raise. This is not a nerve problem, okay? But the guidelines does say this commonly occurs with radiating pain. So yes, if the discal tissue is pathologic, it may be just one step away from being a full-blown herniation, which might include then a radiating pain problem. Then the nerve root's involved. And in that case, you have back pain with related leg pain and back pain with radiating pain. Okay, so in the interventions here, what you're going to see is ideally manual therapy that helps to continue to centralize the problem, right? Lateral shift correction, improving lumbar extension, and we're going to train them to not excessively flex at the lumbar spine. In functional movement, we're going to teach her to not excessively rotate during gait, right? We talked about rotation being a problem, as well as teaching them how to keep the spine in neutral during function, right? So these are all your functional movement corrections. Okay, don't forget your patient education. And that is back pain with related leg pain, discogenic referred leg pain. All right, we'll see you guys in the next chapter or the next discussion.